Hey everyone, I wanted to take some time to do an exam review with you all for the fall semester tutorials final written exam. And let me just start by going over the exam blueprint. Okay, so you will find in Courseworks a module that's titled Final Exam Preparatory Materials. Okay, so go to that module. You're going to find in that module something called an exam blueprint. I'm going to open it and show it to you in just a second, but basically this goes over all of the content that's going to be on the final. So everything is very transparent. It also, in that same module, contains all the other material that you'll need to refer to in your preparation for the exam. All right. Um, and let me just say that, question comes up about, what's the content in this exam. What we're trying to do basically is say, what is the foundational knowledge that you need to be able to transition to the MCY in a successful fashion? Foundational material relating to the history and physical exam and clinical reasoning for very commonly encountered conditions. That's really what we're basing this on. Okay, so um, on this review that's recorded here, I'm not going to be covering all of the content that you'll need to review, but I will cover a good amount of it. And let me just give you a little bit of background about why we have a written final exam, and then I'll show you the exam blueprint. I've gone over this model with some of you before. It's something called the RIME model for development of clinical skills. And basically, RIME stands for reporter, interpreter, manager, and educator. The last one can also be called expert. What you're doing right now is going from the role of the reporter, which is, hey, I'm able to collect all the history and physical, all the data, to the next stage, which is interpreter, which is, now that I have all this data, I can interpret these data to make some sense out of what I think is going on and what we need to do next. To function as an interpreter is your main role when you go into the major clinical year. So starting January, you will be asked to really function at the level of the interpreter. So the question is, well, what do you have to be able to do, and what do you have to know to be an effective interpreter? So it requires a skill set and it requires a knowledge base. The skill set are the things that you've been learning in this class: how to take a history, how to do a physical exam, how to do a write-up, how to do an oral presentation. All of those are going to allow you to function at the interpreter level. But also a knowledge base. The knowledge of the material that you've learned in BHD, absolutely essential. But what you'll find here is it's also a particular set of knowledge that you're learning in our course, in tutorials, that you might not learn elsewhere, that you will also need to know to be able to function effectively. So that's why we want you to have this knowledge base to be able to reinforce what you'll need to be able to know to function effectively in MCY. Okay. So what we're going to do in this recorded talk is to review the highlights of the material that you will be tested on, and it is aligned with the final exam blueprint. Okay. This doesn't substitute for a more in-depth review, but if you use this recording along with your blueprint and you go to your materials and kind of read along with that same kind of map that is outlined in the blueprint, you're going to be fine. It does require some studying, but you're going to be fine if you use this video along with the blueprint and the materials that are posted. It will, you'll be able to learn what you need to know for the final. Let me just click out of this real quick and show you what the blueprint looks like. Okay, so here is the blueprint. Okay, so this is what you guys have on Courseworks. What this basically says is, there's 60 multiple choice questions. It's focusing on core content. There are no surprises. There's no tricks here. This is absolutely foundational material. And it lists here the material that, the questions are taken from. Again, very specific. And the rest of this blueprint lists specifically what questions are being asked, and it tells you how many questions are being asked about that particular topic. So if you use this blueprint and review, for instance, chronic cough in the outpatient setting from this source, and you feel like you know that, and you move to the second topic, sore throat, from this source, you feel like you've learned that, etc., you will be very well prepared for the final. All right, so hope that makes sense. And what I'm going to do now in this rest of this presentation is go through this list one by one, by one, by one, by one, and we'll do a quick review. Okay, so that's the exam blueprint that you know about. First, let's start with the symptom to diagnosis. What are we going to cover in the final from this? We're going to cover 4 topics: cough, sore throat, dysuria, and abdominal pain. So the first is chronic cough in the outpatient setting. Very common. And if you think about this differential, allergic causes, pulmonary causes, cardiac, GI, and medication causes, it'll be a nice way for you to approach this very common problem. So check out these tables. This is going to really help you. I'm not going to go into exquisite detail here, but just go through these tables on your own to see, for instance, what history and what physical can help you distinguish, for instance, post-nasal drip from asthma and from GERD, right? History of obesity, for instance, associated with GERD. History of sour bitter taste in a patient with chronic cough in the outpatient setting associated with GERD. Worse when lying down or after meals, GERD, okay? For this person, may have a history of allergy or eczema, itchy eyes. If they have a, dripping sensation down the back of their throat, if they clear exam on exam, or clear their throat on exam, all those things more associated with allergy. And with asthma, if they have, particular triggers like cold or exercise. If they do have shortness of breath or wheeze, that can also indicate reactive airway disease or asthma. So this slide is just for you to review on your own and learn from. This is what you need to know to be able to answer those questions appropriately. The other things to consider: heart failure and ACE inhibitor cough. So just review these slides for preparation. Sore throat in the outpatient setting. This is also very common. And as we know, it can be caused by viral etiologies, bacterial etiologies, or non-infectious. And here too are critical history and physical exams that are going to be really useful. We'll go over center criteria again later, but basically this can help you actually rule out bacterial strep infection. It's not good at ruling in, but if you have 0 criteria or 1 criteria and other features that are not consistent with bacterial infection, you can avoid antibiotics in these patients. But we're going to come back to center in a few minutes. But again, review these slides. It will help you distinguish sore throat etiologies in your outpatient clinical patients. A couple other causes of sore throat, really useful to know, especially if you have a patient coming in with sexual history, with unprotected sexual intercourse, burning on urination, vaginal discharge. Have to think about gonorrhea as a cause for pharyngitis. All right. Dysuria. Consider the age and other key features. That's what's going to be so key. And what's really interesting about looking at dysuria is by thinking about the age, thinking about the demographics, you can really start to narrow down your causes. Okay, this is a nice slide of someone who's younger coming in with dysuria. So just review this, right? Bacterial, You may have certain features that are not found in fungal, right? And this is bacterial vaginosis, by the way. Right? So if they have this is a UTI or pyelonephritis that can cause dysuria. And of course, you've learned about that. Trichomonas has a particular presentation, a particular finding on the physical. So review that on your own. The key here is on physical exam, you may have an erythematous cervix. It's kind of greenish or yellowish discharge, pain with intercourse, and you have these motile trichomonas on wet mount. For Candida, very common cause of dysuria. There's profuse discharge, can be associated with itching. Patients that are immunosuppressed, like diabetics, can get it. If they've just used antibiotics, they're more prone to get it. And they may have a discharge on pelvic exam. And on wet mount, for your testing, you might see features consistent with Candida. Also, don't forget about viral infections like HSV. If there are vesicles or pustules on exam, really makes you think about herpes. And then don't forget about contact dermatitis, irritation with a spermicide or latex allergy. That can also cause it. Let's move on to abdominal pain. That's also covered in this same session that we had, symptom diagnosis. And what we're going to do here is basically roll through the different quadrants and think about the types of etiologies that cause pain in the different quadrants. Okay, so right lower quadrant, what causes that? Appendicitis, direct hernia, ileitis. So something like Crohn's disease could cause that, or it could be bacterial ileitis, and a stone. A stone that's in the kidney that's traveling down the ureter may cause pain right in that area. It may radiate to the groin. Right upper quadrant, think about what organs are there. You have the liver there, you have the gallbladder there, right? So things like cholecystitis, which is basically a gallstone blocking the cystic duct. Okay, so blocking up the gallbladder and causing pressure, and that can become bacterially infected and presenting with right upper quadrant pain. Hepatitis, okay, so liver pain right over the liver there. It can be caused by a virus, hepatitis A, B, C, for instance, or it can be alcohol, alcoholic hepatitis, or it could be medications that cause the hepatitis in this case. Think about cholangitis also. That's basically an infection of the hepatobiliary system. Oftentimes patients that have a stone from the gallbladder that has traveled to the common bile duct and is blocking up biliary kind of flow out of the common bile duct, and then you have all that bile then becomes infected. So those patients are going to have right upper quadrant pain, jaundice, because you don't have proper elimination of those biliary products, and you may have fever as well. So fever, right upper quadrant pain, jaundice, cholangitis. It's a bacterial infection. Left upper quadrant pain, so a little less common, but it can happen. So think about things like splenic infarct, if there's a patient that makes sense for. Nephrolithiasis again, someone who's having a stone, maybe higher up in the pelvis of the kidney, for instance, or a colonic process. If you have a ischemia of the colon, or if you have constipation, things like that can cause pain there. And then left lower quadrant pain, diverticulitis is a very common one, especially, and here's the key in terms of risk factors, especially in what population? The elderly and those who may have constipation. Sigmoid volvulus, who gets it? Elderly. Okay, so that is a condition that may end up causing abdominal distension because you basically have an obstruction of the large bowel and a lot of pain, left lower quadrant. Also, always think about the common things like constipation. Epigastric, okay, so if you think about what's in that area, the stomach is there, the duodenum is there, the pancreas is there, the part of the liver may be there as well. So some hepatic, Causes of pain can also cause pain in the epigastrium, but in addition, peptic ulcer disease. Who gets that? Someone who's on NSAIDs, right? Someone who may have a H. pylori infection that hasn't been treated. Pancreatitis, right there in the epigastrium. Who gets that? Someone who's had gallstones in the past and someone who is a heavy drinker, alcohol. You can also get autoimmune pancreatitis as well, or viral pancreatitis, but the more common causes are gallstones and alcohol. Gastritis, so someone who's taking NSAIDs, for instance, or has a H. pylori infection, even without a frank ulcer, can have gastric irritation and pain in that area. And then think about the hypogastric or suprapubic area, the bladder, someone who has cystitis, prostatitis in a man, uterine fibroids or endometriosis in a woman. And then pelvic pain in a woman, I apologize for not using a woman's illustration there, an illustration of a woman. I should have done that. But in a female patient, pelvic pain in that whole area can be a lot of different things. We talked about endometriosis already. Pelvic inflammatory disease, or PID, can be an ascending infection of gonorrhea or chlamydia, which can affect the fallopian tubes. Ectopic pregnancy is definitely something that is a cause of pain in the pelvis. Ovarian cyst, ovarian torsion, uterine fibroids, we already talked about in UTI. So in a woman who is of reproductive age, coming with pelvic pain, have to make sure to get a pregnancy test first thing. You definitely don't want to miss a ectopic pregnancy. Or someone who is pregnant, even if it's not ectopic, you may choose to do different imaging as opposed to giving someone imaging that may expose the fetus to radiation. So, women of reproductive age, make sure to get a pregnancy test. So, abdominal pain and maneuvers that we do, we want to check for tenderness. So, these previous slides asked us to really localize the tenderness, but also look for peritoneal signs. What is that? What is peritoneal signs? Those include rebound tenderness, which means when you press the abdomen gently, it hurts, but it hurts more when you abruptly let go. Also, peritoneal signs include, a very light touch causing exquisite pain, or what's called involuntary guarding, which means the abdominal musculature is held in a rigid conformation, and that rigidity is not voluntary. It's not volitional by the patient. It's just rigid by nature because of the peritoneal inflammation. So what causes peritoneal signs or peritonitis? Anything that causes basically a spilling of GI contents into the peritoneum. So duodenal perforation, colonic perforation, gallbladder perforation, a ruptured appendix. All these things are basically spilling contents that are usually contained within the organs, spilling them into the peritoneal cavity, which causes a diffuse inflammatory response. And if you have any of those findings, you're going to get surgery involved ASAP. A couple of specific signs that we want you to know about. Murphy sign, you place the examiner's hands in the right upper quadrant with gentle, steady pressure, and you ask the patient to take a deep breath. If they stop breathing mid-breath because of increased pain, that's a positive Murphy sign and is one of the features of cholecystitis. Rovsing sign, it's a sign that is more specific for appendicitis than just tenderness over the right lower quadrant. And what happens here is you press on the left lower quadrant. And when you press on the left lower quadrant, the patient has pain in the right lower quadrant. That is a positive Rovsing sign, and it is concerning for appendicitis. Let's also think about fever in the hospitalized patient. This is coming from Symptom of Diagnosis, Lecture 2. Think about 7 causes. Pneumonia, have to think about pneumonia as a very common cause of fever in someone who's already been in the hospital. I think you guys know about the signs and symptoms of pneumonia. C. difficile diarrhea, very common cause of fever in the hospitalized patient. Think about patients that have been on antibiotics, that have diarrhea. Even if they don't have diarrhea, if they have a white count that's really elevated without a clear cause, please check for C. difficile. Urinary tract infection, especially in men who have prostatic symptoms, okay, if they have BPH, they have, incomplete urinary voiding, or someone who has a Foley in place for a while. Please consider that you may have iatrogenically caused a UTI. Vascular, central lines. It could be an internal jugular line. It can be a PICC line, a peripherally placed line that goes into the superior vena cava. It can be a port. It can be a femoral line. Any of these things can cause a line infection. So things to think about is how long has that line been in there? And you want to examine that line on a daily basis. Check for tenderness. Check for fluctuance. These lines are going to be covered by a transparent covering, right? So you don't need to take those off. You can look at that site just with inspection alone because it's a transparent covering and you can see if there's any signs of redness or erythema. Very common cause, be on the lookout. Pressure ulcers. They can be a cause. It's less likely. And it's especially less likely if it's stage 1 or 2. If it's superficial ulcer, very unlikely it's going to be causing fever in your patient. But if you have a deep ulcer, okay, so if you can see fat, if you can see bone, it's possible that you have a deep tissue infection or even osteomyelitis that could be causing fever. In those patients, when you've ruled out other possible causes, you need to invoke the possibility of pressure ulcers as a cause for fever. DVT, also one of these things where, you consider it once you've kind of ruled out other common causes, unlikely to cause a high fever, but a low-grade fever in a patient that otherwise you've ruled out causes of fever, you may want to investigate for a DVT, definitely by history and physical, but maybe also by Doppler ultrasound. Medications also has to be on the differential, especially when other things have been ruled out, especially if there's a fever and if there's eosinophilia, if there's a rash, if there's elevated LFTs, and it correlates with the time course of starting a medication, especially things like sulfa drugs, antibiotics, anti-seizure medications, absolutely has to be on your differential. Let's think about self-directed learning for a second. Dr. Chase talked about that. The main point about this is it is the hallmark of lifelong learning. So we want you to just internalize this process. This is how you're going to maintain your medical knowledge for the rest of your career. It involves asking a specific clinical question, going to the appropriate source, critically appraising that source, bringing that information back into your learning and using that to inform things like your write-up or your presentation or your diagnostic or therapeutic plan. Okay? We want you to know about the evidence pyramid. What Dr. Chase talks about is that if you are asking a question that is about basic concepts like pathophysiology of illness or the epidemiology, go to textbooks. They are the most reliable, most richly described sources for these types of questions. If you have specific management questions, you may choose to go to things like UpToDate. That is excellent with treatment options, things like that. You might choose to go to review papers or go to clinical guidelines, things like Cochrane. Those are excellent places. If you have a very specific question that is, highly targeted for your specific patient, you might not get the answer in those sources. For those situations, yes, you might do a literature search on PubMed. But for a lot of your other questions, you should be going to higher level sources first. basically the bottom line of what we want you to know about self-directed learning. Now let's move on to the cardiac exam. Okay, here are the different topics that we'll go over and that you'll be tested on. And I'm going to hit the highlights for you here. First, let's think about chamber enlargement and hypertrophy. When you have a dilated left ventricle, we sometimes call that just dilated cardiomyopathy. Okay, so it can be the LV that's dilated, it can be four-chamber dilated cardiomyopathy. But oftentimes when you have heart failure as a result of cardiac chamber dilation, you're really thinking about the left ventricle that's dilated. Many causes for this, really useful for you to know as you enter MCY. Ischemic. So if you've had a big heart attack that's affected the left ventricle, let's say a big LAD infarction, those patients over time can end up getting a dilated cardiomyopathy. Non-ischemic causes, please always think about alcohol and always think about cocaine use. So if you have someone with a dilated left ventricle cardiomyopathy and you've done an ischemic workup and it is negative, make sure to ask about alcohol and cocaine use. Hypertensive heart disease can also cause dilated cardiomyopathy. Sometimes we think about hypertensive heart disease as, oh, these patients get a thick myocardium, they're more likely to get an S4, they're more likely to have diastolic dysfunction. Yes, that's true. But if you have a patient that has hypertensive heart disease that goes untreated and the disease progresses, late-stage hypertensive heart disease can result in dilated cardiomyopathy. On exam, these patients are going to have an S3 and a PMI that's displaced inferiorly and laterally. Those are the main things we want you to know. What about right ventricular hypertrophy? This happens in someone who has elevated pulmonary pressures, because just think about it. The right ventricle has to pump harder to overcome the elevated pulmonary pressures. So anything that causes pulmonary hypertension, chronic hypoxia, which includes obstructive sleep apnea, chronic pulmonary emboli, right? Interstitial lung disease, all these things can cause pulmonary hypertension and can cause the right side of the heart to have to pump harder and therefore develop hypertrophy. On physical exam, what are you going to see? You may see elevated neck veins indicating elevated right atrial pressures, and you may also feel a parasternal heave. What does this mean? This basically means that when you place your hand over the sternum, your palm, you're going to feel an accentuated thump of the heart up against your hand, because the right ventricle is the closest structure to the chest wall. So when that right ventricle becomes hypertrophied, it is pumping right up against that chest wall, and you're going to feel that thump transmitted to your hand as you examine the chest. Now let's think about neck veins, JVP, and the carotid artery. So this is useful for a couple of reasons. One is you want to be able to see what the internal jugular looks like and where the pulsations are to estimate the right atrial pressures. Secondarily, you may need to put a line in that IJ in an emergent basis or in a controlled basis in the ICU. And you need to know the difference between a carotid and an IJ, because you don't want to put a line in the carotid. Okay, so the point of the IJ is you have an uninterrupted column of blood from the right heart. Excellent way of determining or estimating right atrial pressures. How are you going to do this? You're going to measure the vertical vector. Okay, so just the number of centimeters directly superior to the right atrium. And so you can think about the sternal angle, which is right here, as being 5 centimeters above the right atrium. Okay? And so if this is 5 centimeters above the right atrium, and let's say you see IJ pulsations right here, you're going to measure not this distance, not that distance. You're going to measure this distance. How many centimeters above the sternal angle is the pulsations? And you can report that as centimeters above the RA. You can also report it as centimeters above the sternal angle. Either one works. Okay? I hope that makes sense. We've gone over that a couple times, and that is going to be so useful for you clinically. That's why I want you to learn this and just commit this to your memory. Let's think about S1 and S2. Just, please review just the physiology of what causes S1 and S2. The mitral and tricuspid valves closing creates the S1. It's the initiation of systole. Aortic and pulmonic valves closing causes S2, initiation of diastole. How do you tell them apart? Longer pause after S2. S1 is louder at the apex. S2 is louder at the base. Okay? And S2 splits with inspiration. Very useful for you. When you hear a murmur, you have to be able to describe whether you're hearing a systolic or diastolic murmur. And therefore, this is going to be very useful for you to be able to make that description. And ultimately, the diagnosis of what you think is going on. So now let's say you're able to identify S1 and S2, and then you hear a sound. So you have identified what part of the cardiac cycle that sound or murmur is occurring in. If it's occurring after S1 and before S2, that is a systolic murmur. After S2, before S1, a diastolic murmur. S3 is not a murmur, it is a gallop. We talked about this just a minute ago. S3 is an extra heart sound that occurs early in diastole, and it represents the early passive large volume filling of the ventricle, especially if you have a dilated left ventricle. Okay? You're going to be asked that question on MCY. You're going to be on rounds and someone's going to say, okay, what sound were you listening for on this patient who has dilated cardiomyopathy, and, when does it occur, all that stuff. Very foundational stuff, guys. Good for you to learn. So it's going to help you make an appropriate diagnosis and get the right treatment. S4, this happens late in diastole. This is not from passive filling. This is from active atrial contraction against what kind of ventricle? Not a dilated left ventricle, but a stiff left ventricle, typically in a patient that has hypertensive heart disease or someone who has infiltrative cardiomyopathy. Think about things like sarcoid, right? So things that might, or amyloid, things that have caused a stiff left ventricle cause an S4. And someone who has hypertension. This is just about grading of murmurs. We want you to kind of commit this to memory as well, because you have to be able to describe the murmur. And a couple of the benchmarks here is that if there is a thrill, if you can feel the murmur, it gets you a 4. And if you can hear it, even when the stethoscope is partially off the chest, 5. If you can hear it without a stethoscope, that's 6. Okay? Most of the time, you're going to be able to identify grade 2s. And if it's a loud murmur, but not quite being able to feel the thrill, it's going to be a 3. Okay? Let's just think about common systolic murmurs. Aortic stenosis, very common. So it's going to be in the aortic region. It's going to radiate superiorly up to the carotids. It may be associated with a delayed cardiac upstroke, meaning when you put a finger over the carotid artery, after the systolic impulse, there might be a slight delay before you can feel the pulsation in the carotid. Mitral regurg, also a very common systolic murmur. It's going to be down at the apex, soft blowing murmur that radiates to the axilla. Diastolic. These murmurs are best heard with the bell of the stethoscope, not the diaphragm. So you want to get the patient into left lateral decubitus position for both the mitral stenosis, aortic insufficiency murmur, and for gallops, S3 and S4. Get them into lateral decubitus position using the bell of the stethoscope. Because they're low-pitched murmurs, and they require you to get the patient in that position so that the heart comes closer up against the chest wall. Now let's talk about orthostasis, okay? What is this exactly? It's when someone has a drop in their blood pressure that causes dizziness, that causes lightheadedness, that causes someone to pass out even sometimes, and that might even cause the patient to fall down and pass out, okay? So if someone comes in with basically saying, oh, I feel lightheaded when I stand up, or I passed out, I don't know why, you have to check for orthostasis. What that means is the blood pressure drops upon standing. We have normal compensatory mechanisms when we stand that causes the blood pressure causes the vascular tone to constrict, to maintain blood pressure. And the heart rate might increase a little bit too to maintain blood pressure. But what happens in someone with orthostatic hypotension is that those compensatory mechanisms are not sufficient. And so what ends up happening is that when you stand, you get a drop in the systolic blood pressure. You may also get a drop in the diastolic blood pressure. You may have an increase in the heart rate. And it may be associated with those symptoms. Okay? That's basically it. You're going to check the blood pressure and heart rate when they're supine. Then you're going to have them stand. You actually want to check blood pressure and pulse not only immediately upon standing, but 2 to 5 minutes after standing. And you're going to check for the systolic, check for the diastolic. You're going to check for the heart rate. And you're going to see if those blood pressures drop and if the heart rate has increased. And you're going to ask the patient, how do you feel? Did you feel any of the symptoms that you came in with? And these are the different things that cause it. Volume depletion, a big one. Someone has had blood loss, dehydration from just not eating, or maybe medications. If they're on Lasix and it's a high dose for them. If they have autonomic failure from a neuropathy or a neurodegenerative disorder like Parkinson's. If they have medications that cause hypotension, right? Those are all things that can cause postural or orthostatic hypotension. Age also, someone who gets older can have a deficiency in one's compensatory mechanisms. Let's move on to HEENT, the stuff we're going to test on. These are the topics that you will be asked to review, and I'm going to go over them with you right now. Retinal exam, otitis media versus external, central criteria, lymph nodes, parotids, and thyroid. First, just a retinal exam. We don't want you to be an ophthalmologist by the end of this course. Of course not. What we want you to be is someone who's comfortable in doing a basic retinal exam, someone who can identify the arteries and the veins, and someone who can track those arteries and veins back to the optic disc. If you can do that, you have accomplished a lot in this course, and we're proud of you. So, let's see how to do that. First, find a blood vessel, and then find an acute angle. See, if you find this blood vessel, you see how it branches, and you find the acute angle, and that acute angle forms an arrowhead, and the arrow points in the direction that you will then look. And if you follow it in that direction, it will end up at the optic disc. If you can learn how to do that, awesome. Why do we care about that? Because we want to be able to identify that lateral disc margin to make sure it is sharp. In a patient, let's say, that has headaches and has a concern for a tumor, if this edge is blurry, you're going to get brain imaging ASAP. If someone is hypertensive, comes in with, very high blood pressure, and you do the retinal exam, and this edge is blurry, you're going to send that patient to the emergency department to lower the blood pressure and potentially get brain imaging as well, and look for other signs of hypertensive emergency. Now let's think about otitis media and otitis externa. Otitis media, very common pediatric and adult presentation. You basically have a bacterial, you can have a serious otitis media, you can also have a bacterial otitis media, but basically it's a process of that middle ear. The patient may have pain. The hearing may be decreased because you can imagine if there's purulence in that middle ear space or if there's fluid, even if it's not infectious, you may tamp some of the vibratory transmission of sound. So you may have hearing loss on that side. And when you look at the exam, when you do the examination of tympanic membrane, you may see erythema here of the tympanic membrane or the surrounding area. The tympanic membrane itself may look cloudy, may look erythematous. If you see through it, you might see fluid behind this TM. It may seem kind of cloudy, whitish fluid. There may even be air bubbles in there. And it may look bulging compared to the other side. So whenever you do this exam, compare it to the side the patient is not complaining about to be able to check out to see if it's abnormal. And we want you to do enough normal examinations so you can identify what abnormal looks like when you see it. What about otitis externa? What the heck is that? That's different than otitis media. Otitis externa is an infection of the external auditory canal. So those are the classic example of someone that is a swimmer, basically after swimming might not totally dry out the ears. And what happens is there can be a bacterial infection of the external auditory canal. The classic bacterial agent is Pseudomonas. There may be discharge from the ear. That's the key thing. Patient may complain of pain and watery or purulent discharge. That's key. Whoops. And on physical exam, you're going to be doing something called the pinna tug. You basically grab the ear and you gently tug the ear upward and ask if it causes pain. You may also examine to see if there is any discharge, and in a very gentle fashion, you want to do a otoscopic exam. Be very careful when you put the tip in because it may be tender. So you might not need to go in very far to even see that the patient has some exudate there and erythema of the external auditory canal. We went over this a little bit already, but the center criteria are useful because pharyngitis can be viral, bacterial, or non-infectious. And you want to be able to identify group A strep. Why? Because if you don't treat group A strep, it can, cause rheumatic fever and rheumatic heart disease. It may cause a bacterial infection that actually extends to the peritonsillar space. That can be very dangerous. So you want to identify group A strep when it's present, okay? At the same time, you don't want to treat all of pharyngitis as strep infection because we're going to be overusing antibiotics. So we can use the center criteria. One of the criteria is tonsillar exudate, and you see that exudate right there on the tonsils, this whitish material on the tonsils that here is also enlarged. Okay, so these four criteria: tonsillar exudate, history or presence of fever. If they have that, is more likely to be strep. Lack of cough. The reason for lack of cough is because cough may be associated with other non-strep causes of sore throat. So, for example, if someone has a viral, pharyngitis, they may also have postnasal drip and they may have a cough. Or they may have a cough for some other reason, and they may have a sore throat from just the cough, just the irritation that comes from cough can cause a sore throat. So lack of cough is more associated with strep. And finally, anterior cervical lymphadenopathy, also associated with a strep infection. The key thing about center criteria is that it doesn't really help you rule in the infection. So if you have 3 or 4 positive, it doesn't help you say, yes, it is strep, okay? But you may decide to go ahead and treat empirically, or you may decide to get a rapid strep test. However, if you have a patient that has 0 of these criteria, or 1, and you have a decent alternate explanation, you may choose to not treat, especially if you don't have the rapid strep test available to you. That's perfectly reasonable to not treat in someone with another reasonable explanation and someone with 0 or 1 center criteria. That's the purpose of these criteria, to help you avoid antibiotics in situations where you might not need it. Let's move on to the lymphatic system. What do we want you to know about this? The main thing is we want you to be able to identify the different chains. What are these? Occipital chain, posterior auricular, preauricular, the tonsillar, the submandibular, the submental. Deep cervical can be anterior cervical, posterior cervical, the supraclavicular up here, So be able to identify them on exam and be able to name them. Super important. The other thing is just to be able to tell the difference between a lymph node that is concerning versus a lymph node that, is not concerning. So a not concerning lymph node is something that we call reactive. It's secondary to an infectious or inflammatory process. So someone who has a dental infection, who has a sore throat, who has a recent upper respiratory infection, things like that, can have regional lymphadenopathy. Those lymph nodes are going to be tender, they're going to be small, they're going to be mobile. That is opposed to a lymph node that you'd be concerned about. Something that could be from cancer. Those lymph nodes are going to be larger, they're going to be around for a long time, they may be non-tender, and that may be hard to move because it might be fixed to underlying tissues. That's the main things we want you to know for the exam. Let's talk about the parotid gland. Gland right here, okay? Salivary gland. What causes enlargement of the parotid gland? Several things, including mumps, sarcoidosis, tumors, salivary gland stones. And if a stone, which is called sialadenitis, gets blocked, it can also get infected. Okay, so that can be called suppurative parotitis. So a blocked parotid gland, now that it becomes infected, can be a bacterial infection. And here's the illustration that shows that. And this patient has erythema over the parotid gland. Who gets it? Sialadenitis tends to be older people. People that may be dehydrated also can get it. Let's move on to the thyroid exam. What do we want you to know about this? First of all, where it's located. So, find the thyroid cartilage and go inferior to the thyroid cartilage. Oftentimes the isthmus or the lobe in between, the pyramidal lobe, is located right over the cricoid cartilage. And the left and right lobes can be located over the cricoid cartilage. So very helpful to get that landmark and just move your fingers down to try to find the thyroid. What causes enlargement? Many things can cause enlargement. One is just, hypothyroidism, especially something called Hashimoto, which is autoimmune hypothyroidism, can cause an enlarged thyroid. Okay. Also, multinodular goiter, so a bunch of nodules, even if it's not functional, can cause a thyroid enlargement. Subacute thyroiditis, so this is an inflammatory condition of the thyroid that can cause thyroid enlargement. Those patients may have pain when, tenderness when you palpate over the thyroid, and those patients may have elevated thyroid enzymes as well when you do the blood tests. Also, we have to think about Graves', which is autoimmune hyperthyroidism. Those patients have a diffusely enlarged thyroid gland, so just diffusely enlarged, no lumps, non-tender, especially if someone has what we call proptosis or exophthalmos, which is a kind of bulging of the eyes caused by a deposition disease that is associated with Graves' disease. And those patients, definitely we have to do thyroid studies to see if they have hyperthyroidism. These patients may have also coexistent symptoms of hyperthyroidism, which can include weight loss, fever, anxiety or nervousness. It may involve hyperreflexia as well. Hypothyroidism can be associated with diminished reflexes, especially diminished relaxation of the deep tendon response. What do you want you to know about the skin exam? Very basic things, really. Be able to tell the difference and describe the difference between a macule and a papule. If it's, if something is greater than 1 centimeter, a macule is flat. Okay. I'm sorry. Let me rewind. If you have a lesion that is flat, something that is small, less than 1 centimeter, is going to be called a macule. Something that is larger and flat is going to be called a patch. If you have a raised lesion, something that's small, less than 1 centimeter, is called a papule. Something that's larger is called a plaque. So basic definitions we want you to know. And also something that we want you to really know, because regardless of what field you go into, you may see a patient that has a lesion that if you identify and tell them to get it looked at, you may save this person's life. Do not underestimate this. This can be during your clinical session, even if you're an ophthalmologist or, a psychiatrist, or someone who's just a friend of someone that you notice, a lesion on. Be able to identify the characteristics that are more consistent with melanoma, asymmetry of the lesion. You see how this is kind of, has a lesion over here and it looks different over here. The borders are irregular, not smooth and round. The color is different throughout the lesion. The diameter is greater than 1/4 of an inch, or the size of the diameter of an eraser of a pencil. And there's evolution. It's growing over time. If any of those A, B, C, D, E features are positive, more consistent with melanoma, get it checked out, get a biopsy. You could really help somebody big time. Approach to the abdominal exam. We talked a little bit already about the regional conditions that cause abdominal pain. General points about the approach to the abdominal exam we want you to know for the exam are: we want you to make sure that when you have the patient get ready for the abdominal exam, have them make sure that they have gone to the bathroom first, so their bladder is empty. You want to have them lay down flat on the table. You can bend the knees slightly. That can help. Okay? And if someone's in pain, be gentle with the exam and gain trust with the physical exam before going right away to the most painful spot. And also part of the approach, by the way, is if you need to listen to the abdominal exam, listen before you palpate so that you're not disturbing the abdomen before you listen. You want to localize the pain and tenderness. We talked about that already. We talked about peritoneal signs already. We talked about Murphy's and Rovsing's already. Musculoskeletal exam. Okay, so we'll talk about these 3 things that are going to be on your exam. What causes hand and wrist pain, what causes hip pain, and some maneuvers to do to check for shoulder pain and rotator cuff tendinopathy. So so let's start with osteoarthritis, pain at the base of the thumb. Very common. Please think about this. You're going to avoid a huge workup by recognizing this as a very common entity. This is the location in which it occurs. Okay. Think about de Quervain's. This is a tenosynovitis of the extensor pollicis brevis or abductor pollicis longus. This is an overuse injury. And so the patient is going to put their thumb, make a fist, wrap their fingers around that thumb, and you, the examiner, is going to then deviate the wrist uh, towards the ulna, and it's going to cause pain over the thumb, over this area. Okay? Think about fracture. Someone who falls down on a stretched arm can fracture the Colles, can fracture the scaphoid here. This is going to be tender in the anatomical snuff box. That's the key there. The reason why this even matters is because this may need imaging and you may need to get this surgically treated or casted. This, even if the x-ray initially is negative, if you have pain in the anatomical snuff box, you may need to get a repeat x-ray in a few days, in a week or so, because the initial x-ray may be negative and later on it may be positive. You don't want to miss a fracture there, which may require follow-up with orthopedics. Another thing that causes wrist pain, also super duper common, is carpal tunnel syndrome. Okay, it's the median nerve compression. Please identify, remember the area of the hand that's affected, the palmar surface, the thumb, and the first, second, third, and part of the fourth finger. It may be pain that is radiating. It may be numbness. It may be tingling. Any of those could be associated with CTS. And more likely if you have diabetes or hypothyroidism or obesity, but it really can happen to anybody. It may happen more, symptoms may be present when you wake up. Okay. And of course, you know about the Phelan's and the Tinel test. The Tinel is basically tapping over this area. Phelan is when you bend the wrist and you put the backs of the hand together for a minute and you see if you reproduce those symptoms in both of those provocative maneuvers. Here, some nodes associated with different conditions. Heberden's nodes in the DIP, the distal interphalangeal joint, associated with osteoarthritis. Bouchard's nodes associated with rheumatoid arthritis. Hip pain. What do we want you to know for the exam? One is that intrinsic hip joint pathology. What I mean is the actual hip joint is affected by things like osteoarthritis or a septic hip. That pain is going to be in the inguinal area, and it may radiate down a little bit, but mainly it's going to be in the inguinal area. Okay? We also want you to know about meralgia paresthetica, a compression of the lateral femoral cutaneous nerve. You may have numbness or tingling over the lateral upper thigh. If you have trochanteric bursitis, it's tenderness over the greater trochanter. Discrete tenderness over that bony prominence. You made your diagnosis like that. Sciatica, pain that goes down the leg below the knee, especially with a straight leg raise. That means the exam when the patient is on their back, supine, the knee is kept straight, and you lift the leg up at 30 degrees or greater, and you have pain that radiates down the leg below the knee. That is a positive straight leg raise. That's all you need to know for the exam. Shoulder pain. Now, you're going to get a little bit more of this teaching in your musculoskeletal advanced tutorial, which is in a couple weeks. So review those slides. We're going to put those slides up ahead of time, so feel free to review those slides. But I'm going to go over this very quickly with you. For the exam, we want you to know what maneuvers are consistent with rotator cuff tendinopathy. One is called the painful arc. Basically, you have your arms to your side and you lift your arm up along your side. You basically abduct the arm when your arm is at your side. If you have pain, as you lift your arm up, especially over 90 degrees, that is consistent with rotator cuff. Also, Hawkins-Kennedy maneuver. The person in green is the examiner. So the patient has their arm kind of stretched out, elbow bent, and the arm kind of folded across the chest. What you want to do is internal rotation at the shoulder, which means you bring that hand down. As you bring the hand down and internally rotate at the shoulder, it causes discomfort. AC joint or acromioclavicular joint osteoarthritis. So hand is down at the side of the body, and you ask the patient with their right hand to touch their left shoulder. As you do that, if they get pain in their shoulder, that could be consistent with AC joint arthritis. Biceps tendinopathy, you will see at the insertion site for the biceps tendon along the head of the humerus here. And you'll learn this a little more detail when you do the advanced maneuver session with musculoskeletal exam. But as you palpate in that area over the long head of the biceps insertion, and you have the patients raise their hand against resistance, if it hurts here, that is called the Speeds test. And that's positive and consistent with biceps tendinopathy. Feel free to check out the slides ahead of time, and you will learn about this during your advanced tutorial. Lastly, the Sperling's maneuver for cervical radiculopathy. This is a compression, external compression of the peripheral nerves in the cervical area. Those nerves may innervate the neck or shoulder or the arm or hand. Okay? And so if a patient has pain going down any of those areas, typically unilateral, you can do something called a Sperling maneuver. Okay, it basically consists of asking the patient to turn their head towards the side of the lesion, that actually rotate their head. And you say, does that cause pain that radiates down? Patient says no. Then you say, now laterally bend your head towards the side of the pain. Does that cause pain? If that doesn't, what you do then is have them do all those things while you place a gentle load on the neck. And then you say, does that cause pain down your arm? So in this situation, the patient's head is turned towards the patient's right. That's because the patient is complaining of pain going down the right arm or the right neck, and you're trying to see if a nerve compression is causing it. This patient would be complaining of a left-sided pain in the arm, hand, or neck. Okay? And once again, you're going to be going over the details of this in your actual musculoskeletal advanced tutorial. So quick thoughts about delirium, dementia, upper versus lower motor neuron problems, and some review of neuro advanced tutorial slides real quick. What do we want you to know about delirium versus dementia? Read the practice questions, because the content for this is contained in your practice question. Very basic concept. What it basically means is delirium is an acute condition where you have waxing and waning levels of consciousness, and it's typically due to some acute process. That could be because the patient is dehydrated. That could be because they're infected. That could be because they have a heart attack. That could be because they're otherwise sick and in a strange foreign environment like the hospital. And people that are more prone to it may be elderly. That is what delirium is, something that's come on pretty quickly, where someone's confused, where they have waxing and waning levels of consciousness, and you're looking for a cause, and you're trying to address and reverse that cause. Dementia is different. Dementia is chronic, possibly progressive, okay? It's not some acute condition that has caused it, and it could be memory loss, it could be loss of the ability to perform certain maneuvers, certain, self-care habits at home, things like that. So cognitive impairment that's more chronic, that could be progressive. That's dementia. This is just a slide for you to look at to be able to tell the difference between upper motor neuron and lower motor neuron findings, the lesions, okay? So there are certain physical exam findings, and here are some examples. Just take a look at this slide and start to commit this stuff to memory. I know that you learned this in neurology. You also learned it in tutorials. And it's one of these basic foundational concepts when you're on medicine, family medicine, peds, or neurology, where you're trying to figure out what could be going on and localizing the lesion. So let's think about the pulmonary exam. These are the things we're going to go over. This is a great slide for you to kind of also really get familiar with, which helps you differentiate these various conditions, all super duper common, based on these also foundational exam maneuvers. What does it sound like? What is the percussion like? What is the fremitus like? And some other notes that could be useful. I'm not going to go through this table for you, but we do want you to, you've already been exposed to this, I know, in BHD and tutorials. So just review this. This is going to be super important when you guys get to MCY and beyond. Quick note about tracheal deviation. What do we want you to know about this? Number one, just make sure to look for it. Make sure to assess on physical exam for tracheal deviation. Okay, so it can be seen on general inspection. It can also be seen on a chest film. Okay, so what types of things cause tracheal deviation? Number one, a loss of volume. So if you have a pneumonia and you have lobar collapse, if you have atelectasis, if you have a major pneumothorax, right? Any of those things will cause loss of volume on the side that's affected. That will cause the trachea to deviate towards that side. If you have a space-occupying process, if you have a tension pneumothorax where you have air that is filling on one side, it may be pushing towards the other side. If someone's on a vent, for instance, and you have positive pressure being forced into one side, it could be causing air to fill on that side and the trachea deviating to the other side. Okay? If you have a tumor or some kind of mass that is pushing the mediastinum and the trachea to one side, that can also cause tracheal deviation. Quick notes about wheezes, crackles, and rhonchi. Wheezes, these are high-pitched sounds, prolonged, what's called musical in nature. Asthma is the classic thing we think about, but other things can cause it as well. Okay, if you have someone who has heart failure, some of those people can get reactive airways in the setting of heart failure. You might hear wheeze. Someone with a pulmonary embolism, you may hear wheeze. Someone with a COPD exacerbation, you may hear wheeze. But the classic cause is asthma. It sounds like okay, so high-pitched, prolonged sounds. It can be expiratory or inspiratory, typically an end expiration in a lot of these patients. Crackles, okay? If it's bilateral crackles at the bases, got to think about heart failure, especially if it's acute, worsening of shortness of breath. If it's chronic, it could be fibrotic lung disease. If the crackles are in one particular area and it's more acute, have to think about pneumonia. Okay? Rhonchi are, basically fluid or exudate in medium-sized airways, kind of low-pitched rattling sounds. So things like bronchitis, upper respiratory infections may end up causing rhonchi. Stridor is upper airway sounds. Could be worse on inspiration. If it's upper airway, it may be louder over the neck than in the lungs. Think about it in a pediatric population. Something called parainfluenza can cause a condition called croup, which can cause it. Or if it's an acute stridor, the child is doing fine, playing in the other room, and all of a sudden they have some kind of difficulty breathing and you hear stridor, you are very concerned about a foreign body aspiration. So that person may have a small Lego or some kind of small toy in the airway. So starting to wrap up here, let's think about the write-up. What do we want you to know about the write-up? The chief complaint, we want you to know that it should be brief. It should include, the patient's own words if possible. It should include the temporal time, the time course if possible. The HPI, here's what we want you to know for the final exam. We want you to know what are the essential contents of the first sentence. They include the age, the gender, diagnoses that are pertinent to this admission and in the order of importance. They may also include diagnoses that are really big and too big to ignore, even if they're not necessarily pertinent to this admission. That's it. That's what I want you to know about the first sentence. We also want you to know that right after the first sentence, you have to tell the rest of the story in a chronological order. First comes the background, which means what are the background illnesses that are pertinent to this admission? So if someone's coming in with chest pain and they have a 10-year history of coronary artery disease, the background means right after the first sentence, you start with 10 years ago, the patient had a first diagnosis of coronary artery disease when they were admitted at CUMC with chest pain and found to have a significant LAD infarction, whatever you want to say. And then you bring us up to the baseline. So the background includes kind of in broad strokes what's been going on since the initiation of this particular problem, and then you bring us up to the baseline before the present problem occurred. And then you baseline what's important is what medicines they're taking, what their functional capacity is, what their symptoms are relative or relevant or pertinent to the condition that you're admitting them for. And then you say, patient was at this baseline state of health until, and that's when you get to the present illness. The present illness should contain the relevant aspects of bold carts and any other description you might need to really characterize what's going on. And then you want to make sure to give a pertinent review of systems. Not the whole ROS, but the pertinent review of systems. All of that is within the HPI. The pertinent review of systems is going to be based on your differential diagnosis, right? So if you're considering 3-4 diagnoses in your assessment plan, you're going to be exploring the pertinent systems associated with each of those diagnoses in this section. We want you to know that the formulation should be brief, just 2-3 sentences, and it should contain the pertinent history, physical, and other data important for this case. Assessment and plan, we want you to know that it should contain the differential diagnosis, and then it should contain an explanation of why you have a leading diagnosis and why the others are less concerning but may still be possible. Hope that makes sense. The HPI, the chief complaint is just a brief phrase. The HPI is prose. You want to write full sentences. It is a narrative. It's a story. The assessment is, text. There are sentences, but the problem list is going to be enumerated. And within each problem, you're going to describe in sentences what's going on. What do we want you to know about the oral presentation? First is that it's not the same as the write-up. You want to choose the pertinent components of the write-up to present. Okay? You want to choose parts of the ROS, choose parts of the physical, choose pertinent labs. You don't want to tell everything verbatim because it's going to be way too long and unnecessary to deliver all that stuff. As much as you can, take the write-up and try to commit as much as you can to memory. You're going to have your write-up there for reference. You can always look down. But as much as you can, make eye contact and tell a story and look down at your notes when you need. And just a quick note as you transition to the MCY, practice, practice, practice. This is a skill. Some people are better at it than others. If you're having a hard time with it, don't despair because you will get there. Be patient with yourself. I, for one, had a very hard time with this when I was a medical student. I thought I would never get this right. I thought other people do this much better than me. And with practice, I got better. I got effective with it. You will too. other topics, and we'll end with this, we'll ask you about substance abuse and CAGE. The main thing we want you to know here is just learn how to use the CAGE questionnaire with your patients and what those components are. For ADLs and IADLs, go over your notes. Try to, commit to memory what the ADLs are. Try to get a sense of what the IADLs are and when you would ask about that, why it's important. For advanced directives, we want you to know, when do you ask about a healthcare proxy? Why is that important? What is the role of the proxy when you are in the hospital? Okay, so very high level kind of stuff. You're not going to be asked any super duper specific questions. It's more, what's the function of getting the proxy and some timing about when it's most effective to go ahead and designate things like the healthcare proxy. So let me just end with this painting of the doctor. We want you to kind of think about the role of the physician in the healthcare setting as you make this transition to the MCY. Ultimately, all this knowledge is there in your mind and in your body in order to, be there with patients, be there with families, and give the most skilled, most knowledgeable care that you can give. So when the going feels like it's hard, when you feel, like there's so much to study and so much to learn, just bring yourself back to the basics for why you came here. Why did you choose to go down this path of taking care of patients and families and communities? Because there are people out there that need you. They need your skills. They need your knowledge. They need your attention. They need your care. And the more you strengthen your knowledge base, the better you will be at identifying the best treatments, the best diagnoses, but also the easier it will be to free up your mind and body and energy to do things like support people that need your emotional support as well. Okay, so that's it. Hope this was very useful. If you go along with this presentation, go along with your your blueprint and read along in the appropriate materials, which are your handbook and your slides. You don't have to read your handbook, front to back. Just be directed about what you glance over. Use this presentation and use the materials in the folder, in the modules. You're going to be fine. And please email me if you have any questions, okay? Thank you all.